document, Shaping a Healthier Future, states that no hospital closures will take place until capacity to cope has been built up elsewhere. How does Imperial justify the planned closure of Hammersmith Hospital A&E in June 2014 and Central Middlesex A&E by the end of the year, when there will not be any new provision in place by then?
And I apologise, I did say to Mark that I would give him a chance just to explain the plans first, and then if you can then, at the end, answer Susanna's question.
Certainly. So just to explain the Shaping a Healthy Future plans, and then I'll come on to answer that specific question. There has been a lot of confusion about this. I am a GP locally. I've been working in Acton as a GP for 24 years. I trained at Charing Cross and have worked at Ealing, St Mary's, Hillingdon. So I know the local hospitals well. I was the lead clinician across northwest London about 3.5 years ago, when clinicians coming together were concerned around the quality of care and the sustainability of care, accepting the fact that there aren't any cuts in the NHS, but our funding isn't increasing as fast as the population is increasing or the demands upon it are increasing. So we needed to redesign things to make things better. Part of that was built upon the work that we knew we'd centralised some work, so stroke, heart attack and major trauma were centralised some years ago, and in each of those the care is better, fewer people are dying, and fewer people are left with residual illnesses. And each of those changes had opposition from people concerned around the changes in their local hospital, but each of those care has improved. And so as clinicians we came together, it was the lead GPs in each borough along with the medical directors and the directors of nursing from all of the trusts, the mental health trust and the acute trust, coming together and saying, how do we make things better? And we had long discussions, and we agreed that we ought to work along 3 principles, which were around centralising care where we would make that better, localising care wherever we could, and making sure it worked in a joined up way, integrating care wherever it happened. And having been given this task, and I thought this was going to be fairly unenviable because clearly it meant changes to hospital services, because we agreed that model of care and then spent time looking and seeing what would be the optimal size of a unit. We agreed there should be 5 major hospitals, and clinically there was a united view that that was the right thing to do. It then became a choice, and we went to consultation to ask which hospitals should become specialist, which should become elective, and which could become major. And there was a long consultation over the summer. A decision was made in the end that Central Middlesex Hospital should become an elective centre, and works are underway to make that an elective hospital around orthopaedic surgery, and we'll take a lot of the elective orthopaedic work from across this area and further north, modelling the way it's happened in southwest London where it's very effective. Hammersmith Hospital should become a specialist hospital, and both those hospitals wouldn't have an A&E, and we'll talk more in a second around the closure of those A&Es. Charing Cross and Ealing would be local hospitals and be slightly different, more work would happen, and the work is continuing at Charing Cross where it becomes an elective centre, a major hub for chemotherapy, cancer treatments, as well as a local hospital providing local care, and that work is continuing, and it will have a local A&E after the decision of the Secretary of State.
With no blue lights.
Ealing Hospital will be a local hospital with a local A&E as well. So those are the overall plans, and we're now in the stage after the Secretary of State's statement of planning how we do that and implementing that. And the first of those changes is investment in primary care, and we're doing that at the moment, and we're investing in the ways that GPs work together to produce better community services, working more closely with social services and GPs, and that work is happening. The next stage is the closure of A&Es at Hammersmith and Central Middlesex, because we were given instructions that we should do that as soon as is practical. Now both of the A&Es, Hammersmith A&E, for example, is a very small A&E. It isn't actually run by A&E doctors. It's not run by A&E nurses. It's run by the medical team within the hospital. It manages heart attacks extremely well. They don't actually go through A&E. It doesn't have orthopaedic surgeons. It doesn't have paediatrics. It doesn't have general surgery. So it's not producing what anybody would consider a normal level of care. And the real danger with a unit like that, as at Central Middlesex, is people go there assuming it's an A&E without the proper support. So last week, a car arrived in the Central Middlesex A&E. A girl got out and said, "This is my boyfriend in the back, he's been stabbed." And there's no and there's nobody on site to manage that. So it needed transferring across to another unit to do it. So we're saying, and it's quite clear across the clinical community, that having an A&E that has the full support services is the safest way of doing it. And therefore, because of that, those closures are happening more rapidly.